Our next speaker and the last before our break is Dr. Osvaldo Steven Gigliotti. Dr. Gigliotti is the co-director of the Seton Heart Institute Research Program in Austin, Texas, and he's a PI on numerous clinical trials, and in fact, he's one of the major contributors to the XL-PAD registry. He will be discussing with us management of percutaneous venous disease, clearly a rapidly emerging field in the world of cardiology. Okay. See you.
Get through the trees here. And just advance with the. Which buttons do I use to advance? Turn on your right. It is. All right, so I'm the guy keeping you guys from break, so I'll try not to take too much of your time. I'm going to talk today about management of venous insufficiency, try to give you an overview of the problem, a little flavor, and hopefully pique your interest in this process. I have no disclosures related to this talk. So why am I interested in venous disease? We've heard a lot about arterial presentations today. I do a lot of leg work, and one of the reasons I became interested in this is because in my clinical practice, and probably like a lot of you who practice cardiology, we see a lot of patients referred to us for edema. They have swelling in their legs, they're told that they have heart failure, they come to our office, they get the whole workup, and really everything else checks out normally. The other issue is that when I'm sent patients for arterial wounds, or like this wound you see up in the corner, this really isn't an arterial wound, it's a venous wound. So we go through the workup, they have no arterial insufficiency, and I just didn't like saying, well, I'm sorry, there's nothing I can do for you. And also in your clinical practice, you'll see a lot of patients with discolored legs. This is not just a cosmetic problem. I know you see a lot of times in the like the Dallas magazines, like the Austin Monthly, et cetera, a lot of advertisements for cosmetic vein practices. But really, when it comes to venous insufficiency, this is truly a medical problem. There's a lot of discomfort and pain that your patients experience. There's loss of limbs, loss of work days, and it is a real burden. And it's a very prevalent disease process. This slide will show you that over 25 million people in the United States have some type of venous insufficiency. I think this is an interesting slide because you can see it's 2 times more prevalent than heart disease and even 5 times more prevalent than peripheral arterial disease. And even when you compare it to valve disease, I knew a lot of the fellows coming out looking for jobs, everybody wants to do TAVR and all the sexy stuff, but really when you look at it, there's a lot more venous disease in this country than there is any type of valve problems. Of all the people with venous insufficiency, the majority of these people go untreated. Only less than 10% actually seek treatment. So again, probably an under-recognized and definitely an under-treated process. Patients who have venous varicose veins and venous insufficiency tend to be older, have a family history, have had prior histories of DVT. They are obese patient population, and predominantly are female. So how do the leg veins work? The normal physiology is this is a passive system. As we walk, the calf veins contract and actually move the blood back up towards the heart. After taking a few steps, the pressure in your leg will decrease rather rapidly. When you look at this slide, if you look at the graph, what happens in the normal physiology is that as we're walking, the pressure in your calves go down markedly, as you can see from that graph. The upper line, what you see is people with venous insufficiency, they still stay at a very high pressure. So they're still continuing to have very high pressure in their legs. Over time, having all of this increased pressure will lead to a systemic inflammatory response and leukocyte trapping and activation. Eventually, over time, you get damage to the endothelium, you get elongation, dilatation, and increased incompetence and collagen deposition. So that you'll see on the slide, you get that big, thick, ropey varicose veins, and you also get the overlying skin changes with hemosiderin deposition and other atrophy changes. Again, many of these patients will come to you, they'll complain of aching, heavy legs, a lot of pain. Itching is a very common complaint. These people will all go to your dermatologist, they'll try steroid creams, all sorts of over-the-counter remedies, and nothing seems to work for them. And really what they have is insufficiency. Many of these patients, again, being female, being predominantly, will be on contraceptives or other type of hormone therapy. We'll just go through this quickly. Typically smokers, they'll have a history of prolonged travel. They may have past history of venous insufficiency or DVTs. And then when you see these patients in your office, you're wondering, well, what is this? Is this arterial insufficiency? Is this venous insufficiency? Or is it even a neuropathic ulcer? Typically, when you look at chronic leg ulcers, the majority of these will be venous insufficiency. And when you look at the location, most of these will be around the ankles. So typically, if they've got a wound on the plantar surface of the foot or in the toe, this is probably not a venous problem, but rather more of an arterial problem, or possibly even a neuropathic problem. Or as Dr. Prasad just mentioned, maybe a combination of both. Again, these typically tend to be around the around the ankle. They will have a sort of a pink base with some exudate. May or may not be very painful, and a lot of times have associated varicose veins. We classify venous insufficiency using the SEEP classification, looking at the clinical, etiologic, anatomic, and pathophysiologic reason for this process. This is a very important classification system because reimbursement is dependent upon how you classify these patients based on the SEEP classification. Like most of our scales, the higher the number, the worse the disease process. When you see here is a very mild C1, you see some telangiectasias, varicose veins in C2, edema, and then progressing onwards to different types of pigmentation. This patient has atrophy blanche. I don't know if it shows up very well, but you can almost see this sort of retracted, white, glistening area of the skin. And then all the way to patients with healed venous ulcers or even active venous ulcers. These can be either primary or secondary to things like having prior DVTs or trauma. We define them as whether they're from superficial veins or deep veins, or a combination of both. And again, whether they're from reflux, obstruction, or some type of combination. The real important thing in trying to diagnose patients with venous insufficiency is having a good ultrasound tech and really understanding the ultrasound. A lot of times, patients will be sent for a venous study, and what they get is a DVT study. You'll get a report back saying, oh, they have no DVT. Well, that's not really very helpful. I mean, I probably knew that already. It's really important that you specify that you're looking for a venous insufficiency study. It takes a lot longer, and the tech really has to be competent and know what they're doing to get you good quality results. Really what you're looking for, besides the location and the tortuosity and such, is you're looking for reflux. We typically define reflux as 500 milliseconds in the greater saphenous vein and the lesser saphenous vein, and greater than 350 milliseconds in the perforating veins. Conservative therapy is the mainstay of treatment, usually mostly with compression stockings. Sometimes in different wound centers they'll use different kinds of compounds and agents that they'll put on there, the Uniboot, the leg elevation. But again, this is just treating the symptom. It's really not treating the cause of the wound. There's also some limitations to compressive therapy, particularly in a lot of the patients that we see. We can't use them in people with severe peripheral arterial disease. As you can imagine, if they're already having compromised blood flow and you're squeezing that leg even more, that's going to make things even worse. If they have active infections or diabetic microangiopathy, you don't really want to use these therapies. You want to get your patients, compression therapy, will help decrease ambulatory hypertension, and typically the stockings are exert more pressure on the ankle and less as you move up the leg, which is kind of what you'd expect. You want that blood to go north. They have to be proper fitting, and it's really important that we tell our patients that you have to wear these. The devices don't do any good if they're sitting in the closet. Try to get your patients to lose weight, try to get them to walk, avoid prolonged sitting and standing. When you look at conservative therapy, this trial looked at conservative therapy with compression versus conservative therapy with vein stripping. What they were able to find is that both treatment modalities will heal the ulcer. However, the patients that got surgical intervention tend to have a lower rate of recurrence of the ulcers. This study also confirmed that. Again, both will heal, but patients who receive some type of intervention will have less incidence of recurrence. So typically now we know that doing some type of invasive procedure will reduce the recurrence, give you some faster healing, and improve your quality of life. A lot of the societies now that deal with primarily venous problems tend to endorse interventional therapy. So as an interventionalist, I believe in conservative therapy, but I always feel like I have to do something with my hands and with needles and stuff like that. So I'm going to talk real briefly about treating the greater saphenous and the smaller saphenous vein. This is a procedure that we do relatively frequently with venous ablation. It's a procedure that we can do in our office. You don't need any special equipment or dedicated space. You just want to have a place that's warm because you want to and comfortable so the patients don't experience venous spasm, which will limit your access. There's really no special equipment, just a table, a bed, and you're good to go. Our sonographer will typically re-examine the patient, try to map out the location of the problem and the area to be treated. They'll mark it up for us, they'll prep the patient, and we'll get them ready. We have to access using ultrasound techniques. I don't know if it shows well, but basically you can see the needle entering the venous space, and then you can advance your wire. This is something that you really can't do blind. Standard procedures like we do every day in the cath lab, put your wire in, put your sheath in, and again, advance your catheter. What we see here is that the catheter is advanced to the junction of the greater saphenous vein and the deep femoral vein. You want to make sure you don't put your catheter too close to the femoral vein, the deep femoral vein, because you could get a thrombus formation. We will then infiltrate the area with tumescent anesthesia. This is a combination of saline, bicarb, and epinephrine. And what it does is it surrounds the vein with fluid, allows us to concentrate the energy that we want to deliver to the vein itself, provides some anesthesia, and prevents some discoloration of the skin. This is a saphenous vein before any treatment, and what you see is a fascial plane above and below the vein. And then in the bottom slide, what you can see is that that vein is surrounded by this tumescent fluid. And that provides us, that's exactly what we want to look for. You'll go through and do your ablations. It's just a series of delivering energy to different segments. Sometimes you have to deliver energy to more than one time to a certain segment. But then you just basically walk the catheter on down and take it out of the body. This will acutely denude the vessel, causing it to collapse and causing it to hopefully shut off forever. Afterwards, we just wrap them in a bandage, give them compression stockings to wear for a period of time, and then we'll bring them back within 48 hours to make sure we don't have a DVT or any other problem, and then recheck them down the road. Just to briefly sum up, one thing is when you deliver heat treatment to these veins, whether it's better to do with a laser or with radiofrequency ablation, I think it's basically a matter of preference. There's been a couple trials. Most of them show that both of these treatment modalities are efficacious. Perhaps with ablation, there are less incidents for bruising, pain, and better improvement in quality of life. And this one trial showed that perhaps there was actually an increased incidence of DVTs with laser therapy. So I'll just end that right there, and I'll thank you for your attention.